Our topic is genitopelvic pain and penetration disorder. Genitopelvic pain penetration disorder, or Gpppd, includes dyspareunia and vaginismus. It includes recurrent or persistent difficulties in vaginal penetration during intercourse, marked vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts, marked fear or anxiety about vulvovaginal or pelvic pain in anticipation of, during, or as a result of vaginal penetration, and marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. Risk factors for anxiety or pain around sex include low communication about sex in one's family of origin, previous sexual trauma, lack of sex education, previous emotional, physical, or sexual abuse, anxiety or depression, and negative views of sex. 17 to 19% of American women are estimated to experience coital pain, though these numbers may not be accurate due to embarrassment or stigmatization leading to women not disclosing this information. Gpppd affects 6.5 to 45% of postmenopausal women and 14 to 34% of premenopausal women. Nearly 50% of women affected by Gpppd have another pain disorder, such as interstitial cystitis, irritable bowel syndrome, or fibromyalgia. Gpppd is associated with low satisfaction with one's sex life and is also associated with female sexual interest or arousal disorder. Possible conditions leading to genital pain include genital herpes, candidiasis, tissue lesions from lichen planus or lichen sclerosus, hormonal changes, menopause, and urinary tract infections. Gpppd cannot be better explained by other medical conditions, and therefore necessitates a medical exam to rule out other possible medical conditions, and requires biopsychosocial evaluation, and should not be treated as purely psychogenic. It's difficult to separate dyspareunia and vaginismus diagnostically, and that is why they were combined into the Gpppd diagnosis. Dyspareunia is genital pain during penetration or intercourse. Vaginismus is involuntary muscle spasms strong enough to prevent or interfere with penetration and intercourse. Chronic genital pain that is present with or without contact, but is not classified as a sexual dysfunction, is vulvodynia. There are two main types of vulvodynia. The first is provoked vestibulodynia, or PVD. This is localized provoked pain at the vaginal vestibule or introitus. The second type is generalized vulvodynia, or GVD, and this is unprovoked diffuse burning pain throughout the entire vulva. The pelvic floor operates as an emotional organ, and anxiety results in reflex contractions of those pelvic muscles. Pain inhibits arousal, therefore decreasing lubrication, pelvic muscle relaxation, vulvar congestion, and sexual pleasure. And this decreasing of these things is likely to lead to inflammation and tears and further pain upon penetration attempts. The pain is likely to result in withdrawing from sexual interactions, and this is intensified by hypervigilance to pain, fear of pain, catastrophizing pain, low self-efficacy, anxiety, and avoidance. These things are reduced through higher self-efficacy related to the ability to manage the pain.
Alright, so there are two main goals of treatment of Gpppd. The first one is to reduce genital and sexual pain, and the second is to improve or restore sexual function. Based off of the articles we looked at, the main line of treatment that is recommended is to use a multidisciplinary team. And that will include many modalities, including surgery, medical therapy, CBT, antidepressants, anticonvulsants, physical therapy, psychosexual therapy, electromyographic biofeedback, or topical anesthetics. One interesting thing we found is that the surgery success rate for pain management was twice as high as CBT, but there's also the possible risk of vulvar sensitivity and pleasure is decreased through surgery. So with CBT, one of the main goals is to reduce negative sexual schemas that women have. that might be related to feelings of failure or incompetence. And exposure therapy is also a common treatment, as well as pelvic floor physical therapy. As far as psychoeducation resources, this is one of the main treatment options for treating Gpppd. It's with psychoeducation often includes helping both partners, to understand the problem, female anatomy, and challenging myths about this disorder. We found also in the literature there was a lot of focus on psychoed for people from religious backgrounds, because a lot of women with this disorder come from more traditional backgrounds, and as a result did not have very much education on their own sexual anatomy or on sex in general, and that can contribute to problems with this disorder. And we also found that practitioners should educate clients about vulvar self-care, including avoiding possible irritants, allergens, and douches. And lastly, we found that practitioners should educate clients about the female sexual response cycle and genital anatomy to reduce anxiety by facilitating increased understanding of what to expect from sexual encounters.
So some therapeutic traps to avoid with this is knowing the links that are associated with this with religious upbringings, making sure that you don't get into religious debates with your clients, trying to talk them out of their religious beliefs, but working within their religious frameworks as much as possible. Some other traps to avoid is assuming that women in same-sex relationships are not affected by this disorder. Another trap although women experience the pain, it also affects the partner. Fear of pain leads to penetration and partner avoidance. Some research evidence that we've found with this disorder is that most women that have this disorder have inadequate knowledge of sex. And then we've also found the research shows that 70% of women that struggle with Gpppd come from conservative families that receive little to no education on sexuality. And then for vaginismus in particular, exposure methods, the research shows, are typically preferred because muscle contraction is recognized as a conditioned fear response, and that this can be done through progressively using bigger vaginal dilators. And this efficacy is mediated through reduction of cognitive distortions and avoidance behavior and increased pain control. After the cognitive behavioral programs, women's level of anxiety is lessened and sexual satisfaction and marital harmony is increased.
Issues affecting treatment are that women who come from families or cultures with high standards on women to self-sacrifice are more likely to experience the sexual pain. Also, women who have anxious attachment styles are more likely as well. It's important to understand that women shame our feelings of inadequacy with sexual functioning, especially if there's past sexual or physical abuse. Also, overly hostile or overly sympathetic partners in response to partner's sexual pain are associated with increased pain and lower relationship satisfaction. And lastly, some patients with Gpppd experience severe anxiety about gynecological examinations. They experience fight or flight reactions and the following symptoms: sweating, palpitations, uncontrollable shaking, hysteria, screaming, a desire to jump off the table, hyperventilation, severe trembling, vomiting, nausea, and wanting to attack the doctor. Some ethical and legal considerations are feeling invalidated by the healthcare team. It's very disheartening for women to face sexual challenges and can lead women to not seek treatment. Therapists need to have knowledge of sexual topics because women are more likely to have vaginismus when they lack sexual information, as discussed earlier. The severity is influenced by both anxiety and the amount of vaginal spasms. So it's important to treat both the psychological and the physical. So many women actually do not seek treatment when they have pregnancies, but those that do go and seek treatment, they do find that it is better after having a baby because of just exposure. So many women actually do not seek treatment when they have pregnancies, but those that do go and seek treatment, they do find that it is better after having a baby because of just exposure. Our group did not know a lot about this disorder until after researching, but what we found was that it is not a permanent disorder, and this is something that with therapy can actually really make a lot of difference, and that there's a lot of psychological effects to this. And so it was really interesting to understand that CBD, exposure therapy, and psychoeducation can be a great benefit to those with this disorder. Thank you.